Thanks for the opportunity. I would like to present small incision cataract surgery. All these cases basically were planned for a phaco emulsification with a foldable IOL implantation, but later converted because of the difficulty. So initially, first case which I'm going to show you is a intumescent cataract. So I did a routine staining of the anterior capsule with trypan blue dye, washed it, and then injected copious amount of viscoelastics. And I was expecting a little problem in rexus, but as I predicted, the rexus started extending and the tear extended to the periphery. So I immediately converted. That is the advantage of doing the rexus from the side port before the main incision. So it helps you to easily convert into a sclerocorneal incision. Then a 6 mm scleral incision was made, and then we went ahead with a sclerocorneal tunnel. So sclerocorneal tunnel is made into ensuring that it is of partial thickness, and then make a proper and adequate side pocket, which is very important to lodge the big nuclear cataractus lens. So once that is done, we enter the anterior chamber with the keratome. Keratome goes inside and cuts while going inside, and then once it is done, I just remove the nucleus by sandwich method, and then the cortical aspiration is done, and the IO allied, I intend to put a rigid IO because of the extension of the rexus margin. So first the leading aptic goes inside, and next the trailing aptic is tied inside into the bag. So though the case was little complicated and rexus extended, SICS saved the day for me, and I could place the lens in the bag with a good outcome from the first post-operative day. So this is my first case, and many a times in intumescent cataracts, your SICS will come to your rescue, and that will save you from making any future complications. So going ahead with the second case in this scenario. Second case is also a dense cataract, which was initially planned for a phaco and foldable IOL implantation. I thought initially that this is a type of intumescent cataract, and I can easily do a phaco. I just started my initial steps, put a side port, then stained the anterior capsule with the trypan blue dye, then washed the dye, and then I injected viscoelastics. So while doing rexus, because of the previous case, I thought I should not put a lot of pressure on the capsule. I thought I'll do my rexus little carefully. So I started the rexus by taking a central nick onto the anterior capsule with the cystitome, and then slowly started the rexus. I was very skeptical that it would tear, so I just went on. I slowly did my steps. I didn't fast forward it. I just slowly gave a nick by nick, and I started pulling the capsule, and it was all going on well. And because I was planning phaco, I thought I'll do a little 4.5 to 5 mm rexus. So I did the rexus, and it was quite centrally placed, and I was happy about it. But something told me that this can't be done. Phaco cannot be done. I immediately converted it, but the challenge was to deliver the nucleus from the small capsular opening, but I could lift one pole of the nucleus outside the capsular bag, and then I slowly cartwheeled it into the anterior chamber. So once that was done, the entire nucleus came inside anterior chamber, and I could deliver the nucleus by the sandwich method. So this was a very hard cataract, which was not known in the beginning of the surgery. This is a hard brown cataract. Then I delivered it by the sandwich method, and then IOL was placed inside the bag. So these are many conditions where SICS will come to your rescue. So learning SICS in the initial phase before starting your phaco is very important and good for your surgical expertise. So after inserting the lens, then actually the results are quite as similar to the phaco, because you would have promised phaco and foldable lens to the patient, and you would have converted it. But it's easy to convince the patient because your recovery and your post-op vision is quite good. So in the same way, I would like to show you one more case in the same day. I thought after my rexus. So then the anterior capsule was stained, and then is little elastic in young patients, and if you are not able to get a good CCC, which is very much detrimental for your phaco, the rest of the steps becomes very difficult. So I went on with this thing. I had made up my mind that I'm going to do a phaco. I just went inside and I did a little smaller rexus as predicted, and I was quite successful in doing the rexus. So and then after removing the nucleus, then the cortical aspiration was done, and I could place a rigid lens inside the bag. So all these conditions which was posted for phaco, but I had converted it on table, and all these cases have been done under topical. There was no block given. I had planned for a topical phaco, but I ended up doing a topical SICS. So the take home message would be that SICS is not inferior to any other procedure. It definitely gives you better results, and it also saves you from future complications like PC tear or your nucleus drop if you attempt phacoemulsification in an harder nucleus, smaller pupil, intermittent cataract, pseudo exfoliation, and all such conditions. And if there is any doubt that you can't proceed after your excess, I would advise you to just convert it into a small incision cataract surgery and give the best outcome to the patient, because what the patient is going to see is the first day first show, or when his eye patch is removed, how much vision is going to regain. So the result should be good. It doesn't depend which surgery or you are going to do. So this is this thing, and if any small pupil or any pseudo exfoliation or any zonular dialysis, or if it's an iris coloboma, I would advise you to block your places with a subtenons or a peribulbar block. Take adequate precautions and then go ahead with the case. And cortical aspiration and putting the lens inside the bag, and that's it. I would present on the bag.